Hello, everyone. We're going to give a few more minutes for people to join, and then we'll be starting the webinar shortly. Thanks. Good morning, good afternoon, and good evening, and welcome to today's event. My name is Angela Kanesathasan with the Evidence to Action Project, and it is my pleasure to welcome you to this webinar on new findings from first-time parent programs. We know these are challenging times for everyone, both professionally and personally, and we appreciate your joining us today to discuss a rather special set of young people, first-time parents. Every year, millions of adolescent girls and young women around the world give birth to their first child, and they, with their partners, begin their journey as parents. For young first-time parents, it can be an overwhelming time. From the many sequenced health needs that arise through pregnancy, birth, and caring for an infant, to the changing roles, relationships, and social expectations that come with being a parent. Until recently, first-time parents were largely overlooked by reproductive and maternal child health programs. but over the past 10 years, we have seen an increase in global interest and investment for this specific subset of youth, with tailored programs that provide critical information and services, and also foster the skills and support that first-time parents need to navigate safely through this life stage. Today, we'll hear about 3 such projects from Nigeria, Niger, and the DRC, with colleagues sharing some of the compelling results that have been achieved with young first-time parents. Following the presentations, we will have time for questions and answers. And one note on that, with so many of you joining from all over the world, we've had to mute all attendees. However, we do want to hear from you, and so please feel free to add your questions and comments in the chat box or Q&A box at any point during the webinar. You should be able to access those through the bar at the bottom of your Zoom screen. With that, let's dive into the world of first-time parents. And we thought we'd start by hearing from someone who has a unique perspective on the emerging field of FTP programming. Trish McDonald has been the AOR for the E2A project since its beginning and has been a champion within USAID Washington and with country missions in promoting the unique needs of young first-time parents. She has encouraged projects to build on the successful promotion of healthy spacing of second and subsequent pregnancies and the use of contraceptive methods to also address other issues of importance for first-time parents, from being inclusive of fathers and co-parents, to integrating maternal and child health information and services, and to strengthening couples' communication and decision-making. We're so pleased Trish is with us today to share some thoughts about first-time parents and the opportunity to address their needs. Over to you, Trish.
Thank you, Angela, and good morning, everyone. I hope you're all doing well and staying healthy during this time of COVID as you telework and socially distance and find other ways of enjoying time with your family. I'd like to welcome you all to the webinar this morning and thank you for participating. I'd also like to thank the Evidence to Action, or E2A project, for organizing this event, together with Pathfinder International and the Institute of Reproductive Health at Georgetown University. Nearly 10 years ago, at the start of the Evidence to Action project, one of the first and highest priority activities was to focus on the reproductive health needs of young first-time mothers. Once adolescent girls and young women get married or start childbearing, they often fall between the cracks, as Angela mentioned, between youth programs that often tend to work with in-school and out-of-school youth, and the maternal and child health programs, which often reach women at health facilities. Young first-time pregnant adolescents and young women may have never even been to a health center before becoming pregnant, and they often depend on their spouse or partner and their parents or their in-laws to make decisions about whether they go for antenatal care visits or deliver in a health facility. Next slide. Over time, E2A has identified key milestones in the life course of young parents and explored the family, community, and health system influences that affect many young couples as they move through this series of milestones. They go from being a typical teenager, excuse me, to moving through several milestones, not always in the same sequence, but from a teenager to becoming a couple, marrying, becoming sexually active, pregnancy, becoming parents, and spacing their next pregnancy. There's so many significant milestones that happen, often in very rapid succession, moving adolescents and youth to take on new and socially defined roles as adults once they become parents. It's really no wonder that they need some support as they navigate their way through these life stage transitions. Next. Underpinning this is a socio-ecological analysis to understand the roles that male partners, family, community, and the health system play in influencing how well youth transition through these milestones. These two aspects, taken together, the life course and the socio-ecological model, make up the first-time parents framework and help tailor the programming to the local context. Much has been learned over the life of the E2A project, as well as from other USAID-funded and other donor-supported projects that have been implemented across a number of countries and in different contexts. Through in-depth analyses and technical consultations, The first-time parents framework has been adapted to local contexts with respect to, for example, the ages that different milestones take place and who the key influencers are. Next. Today, you'll hear about the findings from 3 different FTP programs, each from a different country. Yemisi will present on E2A's program in the Cross River State in Nigeria. Akeem will present on Pathfinder International's program in Zinder, Niger. And Brian will present IRH's program in Kinshasa, DRC. It's wonderful to see how this early vision of focusing on young first-time parents has evolved over time. And it's even more exciting to be at this stage to learn about the results from these 3 countries. So let me turn this back to Angela to get us started, and thank you all for your interest in participation in today's webinar.
Thank you, Trish, and thanks for your leadership in this area. It's truly been appreciated. And as Trish said, let's start with our presentations. As a reminder, please do add your questions in the chat box or the Q&A box at any time. Our first presenter today is Dr. Oluwayemisi Femi Pius, who will be sharing results from a recent E2A FTP project in Cross River State, Nigeria. Yemisi is a senior technical manager with Pathfinder International. She has over 16 years of experience in clinical practice and in designing, implementing, and managing maternal and newborn health, family planning, HIV and AIDS, and tuberculosis programming in resource-constrained settings. Yemisi, over to you.
Thank you, Angela. Next slide, please. So in Cross River State, intervention for the first-time parents, we wide the focus on the first-time parents. They are associated with a high risk of morbidity and mortality during pregnancy and also during childbirth. And of course, they're more likely to have rapid and repeat pregnancies. As at the time of the intervention, about 18% of girls between the ages of 15 to 19 years in Cross River State had begun childbearing. 48% of all pregnant women ages 15 to 24 in the South-South geopolitical zone of Nigeria, where Cross River State is located, are expecting their first child. And only 27% of sexually active girls aged 15 to 19 years in Cross River currently use a modern contraceptive method. Next slide. So we had a formative assessment before the intervention, and some of the key findings from this formative assessment was that half of the first-time mothers that we interviewed, both the married and the unmarried, reported that the pregnancy that they had was unplanned. There was limited use of health facility, especially by the unmarried first-time mothers and those with unplanned pregnancy. A review of the ANC registers, at the health facilities showed that most of the first-time mothers, they come to health facility very, very late, even if they come. There was low use of modern contraceptive methods, among these first-time mothers, despite the desire to actually space birth. And the assessment also revealed that partners and the parents, especially the mothers of the first-time mothers, had a strong influence on the health decision-making for the first-time mothers. Next slide. The design of the first-time parent program was a package of both facility and community-based interventions in 2 local government areas of Cross River State, that is Ikom local government and Obubura local government, that had a catchment of about 16 facilities that were supported by the SMGL E2A program in Cross River, and then under the catchment of about 37 communities. The intervention was for 4 months between May and August 2018, and it addressed healthy timing and spacing, of pregnancy and family planning, exclusive breastfeeding with information on use of lamb, and then positive parenting and then the related gender outcomes. We also engaged the first-time mothers, their husbands and partners, and older women, that's their mothers and also the mother-in-laws. And the main implementer for this program was the community volunteers. These were unemployed community health extension workers in the community, and they were the main implementers of the design. Next slide, please. And so for the intervention, we had peer-led small groups for the first-time mothers, and they were having weekly sessions. We had 14 weekly sessions in all, and we had 50 groups in total of between 10 to 15 first-time mothers in each group. We also had group sessions for the male partners, which were weekly sessions as well. There were 6 weekly sections for the male partners, but these groups weekly sessions were led by the community volunteers. The community volunteers also led the activities with the older women, and we had between 1 to 3 sessions depending on the location. And there was structured home visit by the community volunteers for each of the pair group member, between 4 to 6 home visits. And there was broader community engagement on first-time parents, the issue of first-time parents and family planning. And also the family planning service delivery at health facilities was strengthened via mobile outreaches. Next slide, please. And so these were the key topics that were discussed during the group sessions, both for the first-time mothers and the men's group. It was important to note that one of their favorite topics, even in both groups, was the issue around healthy timing and spacing of pregnancy, because both the first-time mothers and the partners agreed that they would like to actually wait before having a second baby. Next slide, please. And so we had, at the beginning of the intervention, we had baseline information, and then at the end of intervention, we had endline data collected. So it was a pre-test and a post-test study to assess their knowledge about family planning, attitudes, and then communication, and issue around contraceptive uptake. Next slide, please. So we saw an improved attitude as regards family planning. So at the formative assessment, a lot of them actually wanted to space their children, but they didn't think that family planning or modern family planning method was the right way to go about it because of their previous knowledge and attitude about the negative impact of family planning. But at the end of the intervention, we noticed that this attitude actually improved as shown by the results. Next slide. Also, there was increased couple communication between the first-time mothers and their partners. For the male partners, the design of the program was that the weekly sessions for the first-time mothers actually started before the weekly sessions for the male partners, because the first-time mothers had to get permission and the concurrence of their partners, whether they would like to be part of the sessions. And so you can see that the baseline for the male partners, they had actually had discussions with their first-time mother partners before we actually had the weekly sessions with them. But overall, there was still an increased couple communication. Next slide, please. And also there was an increased voluntary contraceptive use, for both the first-time mothers and their male partners, comparing baseline to endline. Next slide. And in terms of use of long-acting reversible contraceptive methods, breaking it down by the type of contraceptive method, there was also an increase, especially the use of implants. And this was also seen on the slides, both baseline 16.7% and by endline 49.9% with the first-time mothers. Next slide. And so what were some of our key implementation learnings? The use of first-time mother pair leaders, it was was a strong resource, and they were role models for the other young women, but there was need to actually build their capacity and provide ongoing support for them. Male partners were also important participants in the program, and not just as influencers, but they were co-parents in their own right. Although we had to use special efforts to identify and engage them, we had to use male motivators. These male motivators were actually partners of the first-time mothers peer leaders. And so these were the ones that helped to actually get the other male partners and were able to engage them in the weekly sessions. Older women, they're very, very critical, and there's need to involve them in providing support because they influence the decision-making of these first-time mothers. Home visits was key approach to provide tailored counseling and reference for the first-time mothers, especially for those who would not otherwise seek services, and also provided an opportunity to engage with the key household influencers when the community volunteers pay the home visits. Working with the unemployed CHOOS as community volunteers. In the design, we engaged the services of unemployed CHOOS, and they served as the community volunteers. And this was an effective approach because they have the skills, so in terms of counseling and refer for services, they were able to deliver on that very well. And of course, this has implications in terms of cost and sustainability. Next slide, please. The key takeaways from this intervention was that strong response by the first-time parents and influencers indicates that they are open to health information and services. We saw that even at the formative assessment. We saw that, both at baseline and end, they were very open, they're very receptive, and this is an opportunity for us to address, the full life stage. Community-based approaches, especially home visits, are key to reaching the population and able to actually connect them to the health system, and this will also catalyze, their health action and health-seeking behavior. The responses by the first-time mothers and their partners suggest that there's a good potential for couple-oriented activities, particularly those that explore how men and women communicate and how they manage conflict. Thank you very much.
Thanks very much, Emisi. I'm already seeing a few questions coming in about the Nigeria program, so just a reminder to everyone to please continue to add your questions in the Q&A or chat boxes, and we'll get to those soon. Our next presenter is Akim Asani Oseni, who will be sharing insights and results from a recent FDP effort in Niger. Akim is the acting community-based service manager for Pathfinder in Niger and also serves as technical manager for the Reaching Married Adolescents project. He is an epidemiologist, biostatistician, and expert in intervention epidemiology with over 5 years of implementation experience with adolescent and youth reproductive health projects. Welcome, Akim. Please go ahead.
Hey, Kim, it looks like we're having a little bit of difficulty hearing you. All right, everyone, please bear with us just while we deal with a little bit of technical difficulties. Thanks. Akim, are you there?
Yes.
Oh,
But
yep. Okay. Yes, we can hear you now.
Okay, thank you.
Thank you.
I want to share with you all our experiences in integrating maternal newborn health and family planning programming for first-time parents in Zender region. Next slide, please. In Niger, first-time parent experiences with family planning and maternal child health is complex, and certain challenges are especially pronounced in these settings. Adolescent girls in Niger have the highest adolescent fertility rate in the world, which is driven in part by the high rate of yearly marriage. In Niger, by the age of 18, 76% of girls have already been married and 48% given birth. Furthermore, modern contraceptives are not widely used. This factor contributes to Niger's total fertility rate of 7.6 children per woman, the highest in the world. And such early and frequent childbearing is a root cause of very high mortality and morbidity among mothers and children. These statistics are even more pronounced in Zender region, where the FTP project were conducted. Next slide, please. The FTP project, funded by Margaret Appoint-Cargill Foundation, have been implemented in 48 villages in Zender, Niger, over 3 years, from December 2015 to November 2018. Next slide, please. Working with married adolescents under 24 of parity 0 to 1 who are pregnant or planning to become pregnant and their husband, the project have 3 main objectives. Increase access to and use of high quality family planning and reproductive health services, which include MNH and immunization services. Improving knowledge, skills, and abilities of FTPs to make sound decisions relative to their health and families. This places a strong emphasis on health timing and spacing of pregnancy, and fostering dialogue and reflection among young women, their partner, and the community to shift norms that limit contraceptive choice. Next slide, please. The project was designed around the socio-ecological framework, which linked three levels of intervention. At the household level, activities include gender-synchronized home visits, 10 home visits for women by female relay and six for men by male relay, with messages that complement each other. Small group discussion addressing topics such as communication within couple and health facility referral. The project engaged keepers such as mother-in-laws, co-wives, other family members during home visits, and the broader community through theatrical performance, radio spots, and engagement of religious and village leaders. At the health facility level, healthcare workers were trained to provide youth-friendly services and basic supplies were procured, while Pathfinder's sisters project called Impact played a more robust and complementary role in strengthening services at the facility level, strengthening policies and procedure, conducting mobile clinic, and training healthcare workers on contraceptive technology. Next slide, please. The FTP project was designed using the combined service provision integration model, which is deliberately linked immunization and FP services to be offered on the same day at the same location, which is noted as a promising FP immunization integration high impact practice. Women are counseling on MNH services, FP and immunization during home visits and small group discussion. FP, MNH, and immunization service offered at health center after referral, and curriculum for community health workers and small group leaders emphasizes integration of all the three services, and Pathfinder support facility link models from immunization, maternity with young friendly service, FP services. Next slide, please. So now that we have a sense of where we are come from and where we are going, let us drill further into some of fundings from the FTP project. These funding are drawn from routine service statistics from 16 project affiliated health facilities, household survey at baseline and headline, and 2 cycles of qualitative assessment to inform project improvement. Next slide, please. Next slide. The previous slide. Although the FTP project was primarily focused at the community level, we went in to track FP MNH service usage at the 16 project affiliated health facilities to see if any change could be measured during the project lifetime. What we see is that usage of MNH and FP services have increased over the life of projects. Over an 18-month period increase were recorded in ANC4 visit by first-time mothers and CYP. Youth represented 58% of new FP users during that time. It's also important to note that for the last 3/4 of the life of project, healthcare work streaks have been occurring, which likely impacted service usage. So even with this streak, we see increase in CYP and ANC4. Next slide, please. At the baseline, we interviewed a random sample of young married women under 24 and their husband in the project village, and at end line, we select only those young women who had received at least 7 home visits and the partners to see if completion of near completion of 10 home visit program significantly change FPMNH knowledge, attitude, and or practice. This graph shows significant increase in positive response to all of these questions relative to FP attitude and practice. Especially striking is that 69% of surveyed project participants had a conversation with their husband about using of a contraceptive method, and 97% reported ever have used a modern contraceptive method. Next slide, please. As I mentioned, 97% of surveyed young women at the end line reported ever having used a modern contraceptive method. Although we didn't ask at baseline for the method used because only 3% reported ever using an FP method. This graph shows method choice among those reporting ever having used a modern contraceptive method, which is consistent with method mix among new users at affiliated health facilities. And as you can see, 47% for injectable, 36% for 33% for pills, 15% for implant, and 0.1% for IUD. Next slide, please. Compared to baseline, a statistically higher percentage of surveyed participants at the end line responded very important to the listing question. Question relative to ANC delivery with a skilled birth attendant and at the health facility, vaccination, and postnatal care all showed statistically significant improvement from baseline. Next slide, please. So drawing on the 3 years of implementation and the various results I have briefly summarized today, I would like to share a few key lessons learned from our FTP project. And the first one, migration, particularly of the husband, has been a major challenge, especially for a project that takes a gender-synchronized approach. We need to better account for seasonal migration for men. The project tried to condense visits, shift them to evening, but we want to explore how else to more consistently reach them. At the start of the project, we had challenged recruiting women early in pregnancy, as many women didn't want to reveal an early pregnancy here in Niger. As a result, we adjusted our approach to visit all newly married couples before pregnancy to introduce them the project and become acquainted with the relay. This shift helped it to better engage people early in pregnancy. We also found engaging community leaders and influencers in the project helped it to combat unhealthy rumor within the community about MNH-FP and facilitated engagement with and access to my adolescent, which reinforcing the importance of the socio-ecological approach. And lastly, sustainability was a priority for this project. We worked closely with local MOH from the start to explore what could continue under government leadership. Next slide, please. Some emergency points for future FTP programming are next slide. Next slide. The combination, the previous slide, please. The combination of homework, small group discussion, community activities, and health service strengthening was key to address the unmet need of young people in our context in Niger. Consider factors relative to the environment of first-time mothers that sometimes constitute a barrier to seeking health information and services in the process. My adolescent girls generally live in the family and social environment in which they are not in control of their destiny. They don't have decision-making power, and sometimes the husband who have to decide for her is absent from the village for several months for exodus. Recognize these environmental factors, implement targeted action toward key influencers to generate an enabling environment for the expression and an enjoyable and healthy reproductive life by married adolescent girls, especially those who are parents. By involving mother-in-law, co-wives, religious leaders, etc., in the implementation, married adolescent girls are more receptive and participate fully in the intervention, even in the absence of the husband in the village. Thank you so much for your kind attention.
Thank you, Hakeem. One more reminder to everyone to please go ahead and add your questions in the chat box or Q&A box. Our final presenter is Dr. Brian Shaw, who will be sharing results from a recently concluded program in DRC. Brian is a senior research manager at the Georgetown University Institute for Reproductive Health. He currently provides research support for the USAID-funded Passages project, including studies conducted in Burundi, DRC, Senegal, Niger, and Nigeria. Brian, over to you.
Thank you, Angela. So today I'm going to be presenting on some of our preliminary results, particularly those relevant for first-time parents, for research conducted to evaluate the masculinité, famille et foi intervention, which I'll just call MFF throughout the rest of this presentation, introducing yet another acronym into your lives. And this intervention was conducted amongst faith communities and networks in urban Kinshasa, Democratic Republic of Congo. And the effort is really made possible with funding from USAID. Thank you. Next slide. So MFF is part of the Passages project, which seeks to test, evaluate, and scale up promising interventions that really focus on collective change or norm shifting as an effective means to change those behaviors we're interested in as funders, programmers, and researchers. And the Passages project mostly focuses on sexual and reproductive health, and among populations at key transition points in their life cycle, when norms are a bit more plastic and individuals are potentially more adaptable and open to new norms, which we hope are more sustainable over their lives. So for this reason, first-time parents are a key population of interest within the Passages project, when they may face an environment where the prevailing norm might be, for example, so they're a key population of interest because they're at that transitional life point. So the important point is that we really hypothesize by supporting these norm shifting interventions during these transitional life points, we can better achieve those sexual and reproductive health outcomes that we're interested in. So next slide. So a quick note on how we conceive of social norms within the Passages project. We see social norms as what people think or believe is typical behavior, which we also call descriptive norms, and appropriate or approved behavior, which we call injunctive norms, which is often defined in relation to a reference group or those whose behaviors matter to a given individual. These definitions really help to guide our intervention activities and our measurement and evaluation of those activities. The next slide. So the MFF intervention was developed by Tear Fund, a UK and faith-based organization. MFF is an adaptation of the Transforming Masculinities intervention conducted amongst faith communities in rural Eastern Congo and focusing on intimate partner violence. MFF is an innovation, adding in a focus on family planning and conducted in urban populations in Kinshasa. So the intervention and the evaluation of interest is taking place in 17 Protestant congregations in Kinshasa. And focuses on two populations at those key life transition points, newly married couples and our interest in this webinar, first-time mothers and fathers. Now, the overall goal of MFF is to reduce intimate partner violence and to improve healthy timing and spacing of pregnancies through addressing social norms that shape some inequitable gender relations and potentially prevent the use of modern methods of family planning. So next slide. So So there are a number of intervention activities and strategies designed to achieve this goal, the most important of which is a structured set of community dialogues delivered amongst newly married couples and first-time parents. The dialogues are facilitated by a trained gender champion or positive role models and really urge couples to reflect on existing community norms around gender, family planning, and intimate partner violence through a structured series of gender dialogues, of community dialogues, particularly through exposure to scriptural messaging that is supportive of gender equality, limited family size, and reducing violence within a couple. Faith leaders are also trained to highlight these messages in supportive weekly sermons. And finally, youth-friendly services and referrals are supported with improved health service linkages as part of the intervention. So next slide. So we had an opportunity to evaluate the intervention after 18 months of intervention. And we had several streams of research coming together to evaluate the impact and scalability of this intervention. So for our purposes of today, we'll really focus on a pre-post test with a comparison. It was done with a couple survey, which was conducted amongst couples undergoing community dialogues in 8 intervention congregations, receiving this full MFF package, and compared against couples in 9 comparison congregations, with couples receiving only really the improved service linkage activities, which were done in both the comparison and the intervention samples. Not including those dialogues and supportive sermons in those comparison interventions. So we did this to better isolate the effects of norm shifting activities on our behaviors of interest, family planning, and intimate partner violence. Now, baseline, our sample size was 900 total respondents, among them 386 first-time parents, and 791 total respondents at end line with 474 first-time parents. So next slide. So first, we assessed the reference groups, so those whose opinions and behaviors matter to an individual first-time parent. We saw strong shifts from baseline to end line toward those that considered their partners and health workers as important reference group members, but away from close family members and faith leaders and networks. So this was a bit different from our expectations about faith leaders and networks. We kind of assumed that they would become more prominent reference groups. This could potentially have to do with the fact that in this urban environment, which we haven't done this intervention before, there are many things going on, and faith networks are just sort of one of the normative influence facing first-time parents. And we could talk about that potentially a little bit more in questions. So next slide. So next we looked at voluntary use of method of modern contraception. At baseline, about 1/3 of the first-time parents reported using a modern method of contraception, with no real statistically significant difference between intervention and comparison populations. However, at end line, there was a statistically significantly higher proportion of first-time parents reporting using modern contraception, 44.6% compared to only 34.9% in the comparison population. I also thought it would be a bit interesting to compare this to our sample of newly married couples, where it appears that modern contraception use improved in both comparison and intervention sites, but there was little difference at baseline. So we're seeing that improvement happening in both the intervention and non-intervention population. So our data suggests that there is improvement in voluntary use of modern contraception among first-time parents relative to a comparison. That, for reasons we may discuss during questioning, do not appear to be occurring to the same degree in newly married couples. So I'd like to quickly note that our population shows a much higher voluntary use of modern contraception compared to the DHS population of married women. It's younger, urban, relatively well-off socioeconomically group of churchgoers, and we also excluded currently pregnant couples from our calculations. So next slide. So at end line, we saw some shifts in those intermediate outcomes that we hypothesized stem from MFF activities, namely attitudes and social norms that potentially might be responsible for some of the shift in voluntary use of modern contraception amongst first-time parents that we're seeing. We saw slight improvements in individual attitudes among first-time parents relative to the comparison, with 92.6% of first-time parents in intervention congregations reporting that they personally approve of the use of modern contraception amongst first-time parents. So very, very high individual attitudes supportive of family planning use. So in assessing whether first-time parents perceive modern contraception use as typical amongst first-time parents in their congregation, there really wasn't any difference comparing our intervention sample to the comparison. and only about 1/3 of our sample perceived this to be typical behavior in the congregation, despite that high level of individual approval. However, we did see shifts in injunctive norms or perceptions of approved behavior, with higher proportions of respondents in intervention congregations perceiving that modern contraception for first-time parents is approved by faith leaders, faith networks, their important influences, and their partners. So we see some important shifts and differences from our comparison for personal attitudes and for perceptions of modern contraception as approved behavior or injunctive norms, potentially accounting for some of that improvement we are seeing in modern contraception use amongst first-time parents. So next slide. So next we look at our intimate partner violence outcome. Again, we see sort of similar things happening in shifts in reference groups as for modern contraception. Again, with unexpected shifts away from faith leaders as important reference groups for relationship conflict and violence amongst first-time parents. So next slide. So for our next slide, we show self-reported experience of intimate partner violence by first-time mothers in our sample at N-line. So at N-line, we saw fewer first-time mother respondents in intervention areas reporting experiencing emotional violence, 55.8%, and forced sex, 13.2% compared to respondents in comparison congregations. But this really was not statistically different from those comparison populations. However, we did see significantly less reporting of experiencing physical intimate partner violence, slapping, pushing, hitting, amongst first-time mothers in intervention congregations, 14.8% compared to those in comparison congregations, 23.8%. Next slide. So we also asked a similar question to men. So next we show self-reported perpetration of intimate partner violence by first-time fathers in our sample at N-line. So for men, we saw fewer first-time fathers in intervention areas reporting perpetrating physical violence against their partners, 23.4%. And forced sex, 14.3% compared to respondents in comparison congregations. But again, this was not really statistically significantly different. However, we did see significantly less reporting of perpetrating emotional violence, yelling at, threatening their partners amongst first-time fathers in intervention congregations, 55.1% compared to 65.1%. So about a 10% difference. So we are seeing some small improvements in self-reports of perpetration of emotional violence amongst men and experience of physical violence amongst women. So for those intermediate outcomes of attitudes towards IPV and social norms, we're seeing a bit more variation in our social norms measures for IPV compared to use of modern contraception. And we're still running some additional analysis to better help explain that variation and some of those things that we're seeing. So we're running low on time, so perhaps if this is of interest, we could discuss or address this a bit more in questions. So next slide. So I'd like to end today with a couple of key reflections from our team on our experience of evaluating a faith-based norms-focused intervention in urban Kinshasa. So first, it appears that those activities which encourage first-time parents to critically reflect on social norms in their communities and their faith communities and congregations lead to increased voluntary use of modern contraception. Second, faith leaders and communities are key groups of influence for family planning and intimate partner violence, but appear to be becoming less important at post-intervention. Third, the intervention appears to shift injunctive norms, but not descriptive norms related to modern contraception use. And finally, the results related to IPV norms are a bit unclear in relation to some of the reductions in self-reported IPV we're seeing. For each of these three final points, we're trying to learn a little bit more on why this is occurring and planning on conducting some qualitative research to follow up on these key points. So next slide. So thank you. And for my next to last slide, if you're interested in learning more about this project, we have briefs available on our website at irh.org, and intervention and tools and materials can be accessed at the following link for Frontier Fund. So thank you, and looking forward to your questions.
Thank you, Brian, and thanks to all of our presenters for sharing their work with first-time parents. It's really exciting to see the strong results that are emerging from so many different efforts, and not just in health outcomes, but also in addressing some of the gender and social barriers that may be preventing young FTPs from taking health action. So really interesting programs. Thank you, everyone. I'm also excited to see all of the questions that have been coming in. Thanks to all of you participating today. My colleague, Dr. Eric Ramirez Ferrero, the Technical Director for E2A, has been tracking the questions and is ready to share some for our discussion. Please know that if we don't get to your question today, we will be following up in the coming days to respond to as many questions as we can. I also want to acknowledge another colleague, Mira Sarathi, who is a Field Support Technical Advisor with E2A, who is standing by to assist with translations. Eric, over to you to lead us through the Q&A.
Great, thanks, Angela. Great, and thank you for all the great presentations. In response, as Angela said, we've got a number of questions, so let's start off. Yemisi, this first one is for you. Does Dr. Femi Pius have any reflections on the high use of implants at Endline? Was she concerned about method skew given the use of implants greater than 60%?
Okay, thank you very much, Eric. Well, for the use of implants at Endline, it's important for us to know that at the same time when we're doing the intervention for the first-time parents, the Cross River State government was actually implementing the scale-up of the tax-shifting tax-sharing policy as regards the community health extension workers, the ones that are employed in the health facilities, being able to provide long-acting reversible contraceptives, that's LACs, in particularly implants. So for Cross River State, they domesticated the national tax-shifting tax-sharing policy. And so at that time, they were training to provide implants for clients. And most of the health facilities in Cross River State are led by a CHU. And so there was an increased availability of implant services in those health facilities at the time. And that kind of was in line with the decision of the first-time mothers to space, their pregnancy. So there was no concern of method skew. Was that if you recall at the formative assessment, they did indicate their interest to space their pregnancy, to delay having the second baby, but then they had concerns about the family planning methods. And so with the intervention and their understanding of how family planning work, and then the fact that the implants were now readily available in the health facilities in those communities, and that's explained why we had a lot of them taking up implants.
Great, thank you, Yemisi. The second one is for Akin. The question is, I'm interested to hear more about how religious and traditional leaders were engaged in the program in Zinder, and what is the evidence that their involvement in the program helped to combat unhealthy rumors?
Ok, Hakim, la question est, je m'intéresse à savoir plus sur la façon dont laquelle les chefs religieux et les leaders traditionnels étaient impliqués dans le programme Azender et quelles étaient les preuves que leur implication dans le programme a aidé à lutter contre les rumeurs malsaines. Merci.
Ok, donc merci pour cette pertinente question. Alors, vous savez que nous sommes dans un pays à 99,9% musulmans. Donc, et toute intervention, aussi bien au niveau communautaire, pour qu'elle réussisse, il faudra la contribution des leaders religieux. Et donc, nous, ce que nous avons commencé par faire, c'est de développer un argumentaire religieux qui ressort des hadiths et des versets coraniques soutenant la planification familiale et qui permet de convaincre les leaders religieux de l'effectivité de cette activité-là et de ce que l'islam accepte la planification familiale et les questions de santé de la reproduction. Et cela a permis de pouvoir organiser des conférences de prêche dans les villages d'intervention du projet qui sont animés par des leaders religieux choisis dans les communautés. Ces leaders sont des personnes les mieux écoutées de ces communautés-là. Et cela a permis vraiment de rallier d'abord les chefs de village à la cause. Et cela a aussi permis de convaincre la communauté sur l'effectivité de l'activité et sur le soutien de l'islam par rapport à cette intervention.
Thanks. So Niger is a 98.9% Muslim country, so all interventions, particularly at the community level, need to make sure that religious leaders are involved. And so they did this in the program in Zinder by developing religious arguments using hadith and the verses from the Quran that are in favor of family planning to help convince leaders of the effectiveness of family planning and also that that Islam accepts spacing birth and supports reproductive health. So this allowed us to go into villages and have the religious leaders conduct sermons using those religious arguments for family planning. These leaders were chosen by the community and they're best placed to rally the village leaders or traditional leaders to also become aware of the effectiveness and the accessibility of family planning in their community.
Great, thank you, Akeem and Mira. And keeping on this theme of religious leaders, there's quite a few questions coming in for Brian on the same topic. And here's one. What are possible reasons why faith leaders became less important influencers of contraceptive decisions over the life of the project?
Yeah, so I would like to say that this is in contrast to what we found in our rural populations in Eastern Congo, and also we're replicating this intervention in Nigeria. So it may be that this is just sort of a special case of urban environments to where there are there are many other communities and normative influences that these respondents are potentially facing. So that may be sort of an important point about focusing on faith networks. Also, I didn't get the chance to give the sort of caveat that this also coincided with a run-up to the election in DRC, which actually decreased church attendance quite a bit. So there was some instability kind of going on in the background, which could potentially help to explain that a bit, in that some of these individuals are having less contact with their faith networks in this sort of time of instability. So this is something that we didn't really see in our rural population, or when we were conducting this in rural areas, but it is of special interest in urban populations. And again, we sort of hypothesized that there's many other sort of normative influences that are competing with these faith influences as well, with that important caveat that it sort of happened against the background of some instability.
Great, thank you, Brian. Yemisi, I'd like to turn this one over to you. Have you been able to integrate any non-health issues into programs for FTP, especially in terms of economic opportunities or education? But if other presenters would like to contribute to that question, we'd like to hear your response as well. But let's start with you, Yemisi.
Thank you very much, Eric. Yes, while we were trying to implement the program, we considered some of those interventions. And at the time, we had some government-related activities that were, to help with income-generative activities or economic empowerment for women, and then for return back to school education. So the effort was with the community-based organization to follow up, concerning some of those government interventions, to see how they could link the first-time mothers, to access some of those interventions that were ongoing in the state. But there was a bit of delay in terms of, the states actually doing their part at the time we were conducting the intervention.
Okay, great, thank you. And I would like to go to Akeem now with a question. We had a couple of questions for you, Akeem, about men. Do you have any results for the men who participated in the project? And were there any challenges in engaging them in project activities?
C'est une question pour Hakim. Il y avait quelques questions sur les hommes. Alors, avez-vous des résultats pour les hommes qui ont participé au projet et y avait-il des difficultés à les impliquer dans les activités du projet?
Ok, merci pour la question. En effet, les résultats des enquêtes qualitatives que nous avons menées pour informer le projet ont montré un changement de mentalité progressif des hommes ayant participé à cette intervention, notamment d'abord en accompagnant leurs épouses dans l'utilisation des services de santé, en s'impliquant davantage dans le choix des méthodes de contraception et aussi en s'impliquant au-delà de tout cela dans les travaux domestiques qui sont pénibles, comme par exemple aller chercher de l'eau, aller faire la corvée de bois, toutes choses qui n'étaient vraiment pas faciles avant la mise en œuvre du projet dans notre contexte spécifique du Niger. Et la difficulté que nous avons vécue dans l'implication des maris, c'est surtout leur mobilité. Vous savez, nous sommes limitrophes des pays voisins comme le Nigeria, la Côte d'Ivoire et d'autres, le Bénin et d'autres pays où les maris vont souvent pour rechercher le bien-être. Et donc, cet exode-là fait en sorte que pendant une bonne période de l'année, les maris ne sont pas présents dans le village. Alors que notre approche, c'est une approche qui est synchronisée, genre. Donc, on était obligé de souvent revoir notre approche et de condenser les interventions pendant un laps de temps où les maris sont là pour pouvoir les exposer au maximum au message de sensibilisation afin de pouvoir faire en sorte que les changements s'opèrent à leur niveau. Donc, c'est ça principalement la difficulté que nous avons rencontrée à pouvoir les engager dans la mise en œuvre de l'intervention. Merci.
Okay. So from the results from the qualitative survey, we also did see a change in the mentality of men who had participated in the activities. And this is seen in a change in the men who accompanied their wives to access health services. This is implications for method choice and also implications for the distribution of household chores. We saw some men fetching wood, water, and more traditionally female tasks at home. An issue was the migration of men, as has been mentioned. During a particular season, a lot of men from Niger seek work in neighboring countries like Nigeria, Benin, Côte d'Ivoire. And so when the men leave to go find work, this means that they're not in the villages and we're not able to participate in interventions. So the project was obliged to often change the schedule, rework some of the timing to make sure that they could condense interventions in the times that the men were in the village to maximize their participation. So that was the biggest challenge faced within male engagement. Thank you.
Great. Thank you, Akeem and Mira. And Brian, I want to turn one over to you. About IPV. Do other data from the project, especially qualitative findings, share any insights into the IPV issues faced by FTPs? Are there specific factors that contribute to intimate partner violence during this life stage? And if so, any lessons learned on IPV interventions that might work well for FTPs? There's a lot there, sorry.
Yeah, that's a multi-part question. I think for the qualitative research in terms of specifically first-time parents and intimate partner violence, I think we have some insight into this is a particularly stressful time, the stressors of having a new child or being pregnant, and particularly that first experience of that. We actually see more intimate partner violence in our FTP population compared to our newly married couple population. And we're sort of hypothesizing that it has to do with sort of the stressors of, that experience of having a child for the first time. So in relation to some of our other populations, we're seeing a little bit different, prevalence of intimate partner violence, particularly for first-time parents, and our qualitative study is just sort of confirming some of the reasons that we think that might be. And then, so can you remind me what the other part of the question?
Let's see, hold on. Let's see, there was the insights, the issues faced, the specific factors that contribute to IPV during this life stage, and any lessons learned about interventions that are effective.
Yeah, so at least in terms of that sort of stressful time, just engaging males within these sort of couple dialogues, critically really reflecting around sort of the stresses that they're facing during that time, the unique stresses that they're facing as first-time parents. Talking through those in some of these couple dialogue sessions, as well as having that sort of supportive faith structure, really seems to have reduced at least some of the sort of forms of intimate partner violence within the first-time parents that we've seen in this particular MFF intervention. So it does seem that despite those stressors faced, this strategy of involving both men and women at that critical life phase in these sort of community dialogue, or these couple-based dialogues, guided by these positive role models, these gender champions, and critically reflecting upon those and thinking about those in relation to the stresses they're facing and discussing those, seem to be a relatively effective strategy, much more effective in the rural settings. As I was saying earlier, we had stronger findings from those rural settings, but also seemingly effective as well in these urban populations, at least for some of those forms of intimate partner violence.
Great, thank you, Brian. I wanted to take advantage of Trish's presence actually to ask her sort of a broader question, given her expertise and long-term experience in this area. So Trish, given how this FTP field has evolved over the past 10 years, what are some of the opportunities for future programming that you see? Do FTPs, or should FTPs continue to be a key youth population?
Thank you, Eric. So within USAID, we do have a very strong focus on youth and adolescents. And as we speak, are looking at the different subpopulations within the adolescent and youth categories. We have definitely prioritized young first-time parents as a key population going forward. So as our programs are becoming more integrated, it gives us an excellent opportunity to really look at the whole suite of health interventions and then combine that with a lot of the youth-focused interventions, such as positive youth development and looking at the social norms that influence them as they make these major life transitions from being teenagers or youth to becoming parents and adults in the adult world. So we do see that we have a big future in the youth programming area. We have prioritized young first-time parents as a key population, and there is just so much more to learn and to test out in countries to really find effective ways of helping youth through these transitions, improving couples communication. Really, I think one of the things that these presentations highlighted was the intimate partner violence and understanding more about that. Is it a social norm? Is it an expectation of becoming a man as an adult? Is it the stress of parenthood? I think there's just so many unanswered questions that we look forward to learning more about as we continue designing programming for this particular population.
Thanks, Trish. Thanks for that thoughtful answer. I'd like to end the session with quick comments from each of the main presenters about sustainability. So we received this question, and I think it's a great one to end on. What processes did the project engage in to develop sustainability plans for their interventions? For example, which stakeholders were engaged? How did this engagement happen? How do national governments plan to fund sustainability and institutionalization? So a quick comment from each of the speakers on sustainability plans. Yamisi, let's please start with you.
Thank you very much, Eric. Well, for crossover intervention, one of the efforts we did at sustainability was, first of all, to share the findings of, even the formative findings, with the senior officials of the State Ministry of Health. That's the Commissioner for Health, as well as the Director General for the Primary Healthcare Development Agency. These are the two offices that are in charge of health services, you know, at the state, so that they could understand the need to pay attention, you know, to first-time parents, you know, in any health interventions that the state is planning to engage in. Also, one of the efforts that we did, you know, as a project, was to help the state to come up with some kind of scale-up plan, you know, for family planning services, you know, using the task shifting, task sharing approach. And in this, we had a working group. We had other key members from, you know, the Ministry of Education, you know, from we followed somebody from Ministry of Justice, and so some of these issues also came up, you know, in terms of the role of providing services to first-time parents. We engaged the local CBO, you know, in the state to also build their capacity to be able to ensure that, you know, future programs or future projects that they have the capacity to also address the needs, you know, of the first-time parents, you know, in any future projects or programming, you know, that they had. So these are some of the efforts that we put in place to ensure sustainability.
Great, thank you, Yemisi. Akeem, Mira, same question to you guys.
Et Hakim, alors on pose une question sur la durabilité et la pérennisation des activités à tous les présenteurs. Alors, dans quel processus le projet s'est-il engagé pour élaborer les plans de durabilité pour leurs interventions? Quels acteurs ont été impliqués? Comment cet engagement s'est-il produit? Et comment les gouvernements nationaux prévoient-ils de financer la durabilité et l'institutionnalisation des activités?
Ok, merci pour cette belle question. Alors, nous, déjà depuis le design initial du projet, on a impliqué le gouvernement au niveau local, depuis la direction régionale jusqu'au niveau des districts, dans le peaufinage de l'intervention qui va être faite, et à toutes les étapes de la mise en œuvre, le gouvernement local était impliqué. Donc, jusqu'à l'identification des agents communautaires qui vont mettre en œuvre l'intervention. Et donc, au niveau de chaque aire de santé où l'intervention a été mise en place, on a essayé de mettre en relation les agents de santé communautaire, les relais qui ont été utilisés pour la mise en œuvre de l'intervention. On les a mis en relation avec les agents de santé au niveau local, pour créer une relation de supervision et d'appartenance au système de ces agents-là. Et donc, cela a permis à ce que, déjà avant la fin de la mise en œuvre, tous ces agents-là ont été appropriés par le système de santé en place. Et au moment où on finissait le projet, on a partagé les résultats de l'enquête finale du projet avec le gouvernement local, et ensemble, on a défini les activités qui peuvent continuer sous le leadership du gouvernement local. Et donc, c'est ainsi que certaines des activités, comme la poursuite des activités communautaires du projet, à travers la sensibilisation, l'offre des services de santé adaptés aux adolescents et jeunes au niveau des formations sanitaires, toutes ces activités-là ont été intégrées dans les paquets d'activités annuels du ministère de la Santé au niveau local, au niveau des districts. Et donc, c'est ainsi que chaque année, ces activités-là qui ont été acceptées comme des activités à haut impact ont été intégrées systématiquement dans les plans annuels du ministère, et cela permet d'assurer une sorte de pérennisation de l'intervention après la fin du projet. Et donc, tous les outils aussi qui ont été développés dans la mise en œuvre du projet ont été partagés avec le gouvernement local, et cela a facilité aussi la poursuite de l'intervention à la fin de la mise en œuvre. Et d'ailleurs, dans d'autres localités où le projet n'a pas intervenu, il y a eu des initiatives de réplication du modèle dans d'autres régions où le projet n'a pas été intervenu, en se basant sur les outils que nous avons développés et que nous avons partagés avec le ministère de la Santé. Voilà comment nous avons programmé la durabilité et l'institutionnalisation de l'intervention. Merci.
Okay, so since the initial design of the project, we worked directly with the government at the local levels, from the region to the district. And at each step in the implementation, the government was involved. Each health area, they built a relationship between the project's community health workers and the health providers from the government system, a relationship in which they help with supervision. And then by the end of the project, these community health workers are now integrated into the local health system. The end of the project, we also shared the final results from the final study with the government, and together defined activities that could continue under the leadership of the local government. So this included sensitization, the service delivery you've adapted for young people. And these activities were integrated in the package that is provided through the local health system at a local and a district level. So each year in the planning process, these are considered high impact practices. So these can be integrated into the health plans at the government level. And then finally, we also saw that after the implementation, there are other localities where the project was not involved that replicated these same activities and the same approach. So this is showing a bit of the start to sustainability of these programs.
Great, thank you. Mira, thank you for the comprehensive translation there. I know that's not easy. Brian, I know you have to leave in just a few minutes, so we wanted to get your quick response to this question about sustainability planning and any processes you went through for that.
Yeah, absolutely. So in the DRC, Tier Fund worked very closely and did a lot of upfront work, including as a stakeholder, the Église de Christ du Congo, the ECC, which is a large network of Protestant congregations throughout the country. So they worked to help sort of co-develop the intervention, as well as being apprised of all sort of the developments. So there's a lot of close interaction with this large faith-based network that goes beyond just the population or just the congregations that we were doing the intervention in. So our sustainability plan is really to continue to engage with those sort of large networks and consider sort of scaling this up within those sort of wider networks.
Great, thank you, Brian, and to all the presenters for your great responses. And Angela, I'll turn it back over to you.
Thanks, Eric and panelists, and thanks to all of you who posted questions. As I mentioned, we will be in touch in a few days with additional responses to questions that we didn't cover today, so don't worry, we will be in touch. And that will also include a link to the webinar recording. With that, I will bring today's webinar to a close. Our thanks to all of you for your continued commitment to the health and well-being of young people around the world, and our best wishes for your own health during these difficult times. Thank you and goodbye.